All right. First off, Happy New Year. If I say it at some point, I hope that it just we miraculously are in 2021 and everything's behind us. Kind of kick it forward. I don't know. So we'll see. No one bought that either. Trump's fine. So, so, so welcome everybody. I hope you're having a good week. A little bit of heat out there tonight, but somehow or another it didn't feel that bad. I don't know why, other than being really gross to run in. We have the lovely and talented Ellen Foster joining us this evening. And what I mean by lovely is look at the setup she's got. She may or may not be coming to you from CNN headquarters, where she will be appearing this evening on, I almost said Larry King Live because it's the only person I can think of, but I know he hasn't been on CNN in like 25 years. I know, Leslie, don't shake your head at me. Ellen joins us. She is a PT at Beyond Exercise, a cyclist, almost a professional cyclist. We'll just call her a professional cyclist. It'll make it this easier. A part-time runner and an expert on running and running injuries, however. So that is why she is here this evening. She's going to discuss a little bit about common running injuries and walking injuries. And I'm going to pass it on to her because she's a little smarter, a little nicer, and a little brighter than all of us. So I'm going to let Ellen take over. Ellen, if you need anything at all, just buzz. If you guys have any questions for Ellen, I'll let her decide if it's good to interrupt her. Otherwise, the chat is open on the side of your screen. If you have any questions, you can type them in there, and I'll make sure I get them to Ellen after she's done. And now, Ellen, the floor is yours. I will shut my mouth.
Awesome. Thank you. If anybody has any questions at all, you guys can just interrupt me. It's a small enough group. I will not mind at all. You can just unmute yourself or shoot a question in the chat. Like Rick said, I'm a PT at Beyond Exercise, and we treat hundreds of injured runners every single year, unfortunately, but it's a lot of fun. I love working with runners. Like Rick said, primarily more of a cyclist, but I do run a few times a week, still average about between 20 and 30 miles. And, with that kind of stuff, running a few half marathons, I have dealt with my fair share of running injuries. Show of hands, who else has been an injured runner at any point in their running career? Yes, exactly. It's hard to be a runner without getting an injury, right? I think the stat is 80% of people who run will have an injury at some point, right? And so that's one of the biggest things. You guys have been learning all season about prevention and causes and how to train appropriately so that you're not injuring yourself. And so we're just going to build on that tonight, kind of talking a little bit more specifically about some common injuries. And like I said, if anybody has a specific one they want to talk about or they want me to discuss, I can absolutely do that. But just kind of, reviewing some of the concepts that maybe Eric or Rick or Laura or anyone has spoken about already this season, right? When we're talking about injury, it's definitely a spectrum, right? There are catastrophic injuries. There are little niggles that you feel from time to time. And it's hard to know all the time, is this something really serious? Is this something that a couple of days of rest will help me feel better and get on with my training program or not, right? And maybe you're not even injured at this point, but you're thinking about chasing a PR, right? Anytime you're trying to make those breakthroughs in performance, the risk increases a little bit. And so just remembering that, injury and performance are on the same spectrum, just at opposite ends. And so you can't hit PRs if you're injured, right? So preventing injury is really the first step of setting a PR. Looking at some causes, right? Globally, we know that, training error is one of the biggest causes, just meaning that, too much too soon, you increased intensity, you increased volume, duration, things like that. There are biomechanical things that can cause injury. Not that there are certain, things that you're destined to have an injury if you're an overpronator, right? That's not true at all, but there are certain injuries where we see if you're an overpronator, maybe you're more likely to have a certain type of injury versus someone who is a supinator, underpronator. like Eric spoke about in his kind of strength and prevention talk, that, you know, you are always trying to get the capacity of your body to handle the load of training. And that's where strength training comes in, right? Increasing your physical strength and resilience. So if we kind of jump into certain body parts, I'm going to share my screen so you guys can follow along. And I'm pretty sure that we have this in kind of a written format on our website. Awesome. Can everybody see my common running and walking injuries? Awesome. Perfect. Okay, so we're just gonna scroll down here. Like I said, more than 80% of runners end up with an injury at some point. We're gonna kind of break it down into different body parts, because the main takeaway I want everybody to get from this evening is that even in one region or joint of the body, there are many, many, many causes and many different diagnoses that you can have. And so this is one of the things, I think, one of my biggest piece of advice for tonight is knowing that sometimes when you Google things, it's not necessarily going to be the best advice. And we're going to talk about how to kind of combat that and sort through what's online, and, you know, making those decisions about, like, is this a true injury? When do I seek help? When can I self-manage? Things like that. So as we go through, I'm going to not just read off the slides because you guys can read. And like I said, this is online. But, you know, when we say thigh pain, if you just Google thigh pain, you have to be very specific about the location of where that pain is coming from. Most of the time when we're talking about regions between the joints of the body, you know, it's more likely muscular in origin. So if you look at all these thigh pains, we got quad, hamstring, and adductor, which is that inner thigh muscle group. And all three of those are big muscle groups that help power our running stride, and they can all be injured, you know, different ways, right? But if you look at, you know, some of these symptoms, they are literally exactly the same, right? Oh, pain with walking and running, going up steps. Sometimes hamstring, you can tell it's like in the back, bending over. But really, you know, you have to be specific. And this is one of the things about seeking help that's really helpful, to have a PT kind of look at you and be able to tell exactly what structure it is that we're looking at. So then if we go to hip, butt, low back, right? That region, when a lot of people come in and they tell me they have butt pain or low back, but it really turns out to be glute and not so much back. Again, a lot of muscles there that can be injured. All three of your glutes, which are super, super important muscles to strengthen. I hope you guys have taken that away from any of the strength training stuff this year, that they really help prevent a lot of dysfunction. So when those muscles are a little weak, they can become strained, right? And you'll have that pain, whether it is the point of your hip on the side. A lot of times doctors used to diagnose this as bursitis, inject it with cortisone, and then it didn't really go away, right? But now we know it's more likely a tendonitis or strain of the glutes. And that pain can also be felt in the butt itself, right? And so a lot of times this glute max and piriformis syndrome can be pretty common and similar. And the same with SI joint dysfunction. Any of these, you know, sometimes it even takes me a couple sessions with someone to really decide which structure is injured. And so if you're just trying to find out online, it can be definitely difficult to figure that out and follow the correct advice, because you'll get different advice for every single one of these injuries online. And our treatment will be very, very different depending on what structure is injured. And a lot of times in this region, right, you know, we get that referred pain where if you're having problems with any of these things, you might get pain all the way down your leg, down your thigh, the back of your knee, and your calf. The glutes especially have a referral pattern that when you get trigger points from, you know, chronic overuse, sometimes people will feel it in their lower leg. A few more things that can be going on in that same region, right? You can get a stress fracture, probably one of the most dreaded diagnoses that we see, and every runner kind of fears, because it is, you know, you might say more serious, requires a little bit more conservative management rather than, you know, like, oh, let's see if we can run through this. Lumbar muscle strain, another really common one. Psoas muscle, right? Everybody thinks about it being a hip flexor and hip flexors being really tight, but because of the attachment on the lumbar spine, you can have back pain as a result of the psoas muscle. And again, even more stress fracture. I think that's a double slide.
Where is the psoas?
So the psoas muscle, it is attached to your spine underneath all of your guts. So behind your stomach, behind your intestine, and then it comes through your hip flexor and attaches to your femur. So it is like your hip flexor, where a lot of people traditionally are stretching their hip flexors. You feel tight and pinchy in the front of your hip. There is some,
So it's in the front, not the back that you would typically feel it?
no, you can really
Oh,
feel either one.
okay. I was just curious.
Yeah, it's definitely an interesting muscle because there are PTs, chiropractors, doctors who swear that you can palpate it, meaning that you can touch it with your fingers if you dig into someone on the front side of them. And then others believe that you cannot because there are a lot of things that you have to dig through to get down to, right? So I don't know if you guys have seen, there are devices for everything. This is one of the other problems with the internet, right? Everybody's created something to release any one of these muscles, like the psoas. So there are these devices. One is called the PsoRite, that it has like, it's a piece of plastic and has these two aggressive spikes that stick up like 4 inches, and you're supposed to lay on the like through your stomach and then take nice deep breaths, and it supposedly is releasing your psoas. I don't think that really works.
It sounds so wrong, not so right.
Very painful. So this is
horrible.
This is one of the other things with running injuries, is that, the idea that, even the therapy for it is going to be really painful, right? Dry needling is definitely not comfortable. Active release and different release and foam rolling techniques are uncomfortable, but sometimes it doesn't have to be that bad, right? They're not all torture devices. Knee pain is by far the most common running injury, right? People come to us with knee pain. And like I said, the knee alone probably has 20 different causes of knee pain in a runner or walker, for many, many different reasons, right? And so some of those, simply the tissues can be overloaded, right? If you're increasing that mileage or that intensity, or you're doing hill repeats, running up or downhill can really kind of set the knees off. I know a lot of people come back from Boston with unhappy knees or quads, right? And again, you can't just Google like knee pain runner, because like I said, look at all of these things. Almost every single one says it hurts going up and down steps, going up and down stairs, walking uphill or downhill, but they're all different things. And so you can't treat them all the same. Yeah. So then a few more, right? They're just different structures. So when you're looking at the knee, some of the structures that we're looking at that can be irritated, the quad tendon, which is above the kneecap, the patellar ligament below the kneecap, the patella itself, or the cartilage on the underside of it, all of that can get irritated just from normal mechanics, right? The knee is definitely one of those joints where if you have bad running mechanics, it's going to take the brunt of it, and it's going to be very, very unhappy. If those glutes are not engaged, if your quads are not strong, the knee is going to be the one that talks back to you the most. And so that's one of the reasons why it is a very, very common source of pain that we see. And those are all just kind of normal things, right? Where you're not necessarily damaging any structure, they're just irritated. So there are some structures in there that can be injured, right? Ligaments, the meniscus, never fun, because sometimes it's not sharp pain. Sometimes it is just enough discomfort, feels weird, feels unstable, it clicks, it pops, where your running stride is affected, and then other tissues are overloaded. And so again, any of these, even though these are internal structures, we're able to assess these in the PT office without the need for MRI or X-ray, anything like that. And that's one of the reasons why I think in almost every single state now, you are able to go into a PT without a referral from an orthopedic or a doctor, right? PT can be your point of care person that you see when you have a problem. And it's anybody's choice, but I think that we get people out there faster than if you go through the whole process of seeing your GP, and then they send you to an ortho, and then the ortho does imaging, and then they send you to a PT because the X-ray doesn't show anything that's wrong. And then they do, they say, well, you're not going to do an MRI yet. And then maybe eventually you get an MRI, and that could be, a 6 to 8 week process, depending on if your ortho has any wait time, and if imaging is happening or if it's considered a ancillary service that's not necessary right now, right? We saw a lot of backup during the pandemic when they stopped doing orthopedic procedures, and then kind of the rush of people after everything started back up again. So then let's see, lower leg pain, shin splints. Everybody loves those, right? So painful. And then stress fracture in the same area. And this is definitely one that it can be tough, having experienced this myself, where you just keep telling yourself it's a shin splint, right? And you're not really going to hurt yourself, and you can kind of deal with it. And then it turns into a stress fracture. Or because you're experiencing shin splint on one side of your leg, you overload the opposite leg and can get a resultant stress fracture or develop shin splints on that side as well, or things lower down, right? So Achilles tendinopathy, this can be one that is really, really stubborn as well. We tend to see it, honestly, a little bit more in men than women. I would say knee pain is pretty equal, but a little bit more in women. And that's what, talking about the biomechanical factors of knee pain with patellar tracking angle. And if you have wider hips, you're said to have maybe a greater risk of knee injury. For the same reason, men tend to have stiffer Achilles tendons, especially as they age. If I could do one thing as a physical therapist, it would probably tell people, middle-aged men who want to play church league softball or rec league basketball, please don't do it, because you're going to hurt yourself and tear your Achilles tendon. But also with running, the risk for tearing it is pretty low, but you can get tendinopathy pretty easily. Tibialis strain, right? That can be the anterior tibialis, kind of up by the shin. More commonly, we see posterior tibialis irritation, whether it's at the shin, right behind that inside ankle bone. It can even go underneath to the arch of your foot, right? And that is something we might see in people who pronate a little bit more. But again, just because you're a pronator doesn't mean that you're going to have that. So then coming down to the foot and ankle, plantar fasciitis and stress fracture. So these are the two things that everybody always thinks they have when their foot hurts, no matter where their foot hurts. If you Google foot pain, the first thing that comes up is plantar fasciitis, right? The problem with that is that, it's not always that, right? The arch of the foot, the base of the heel, things like that. But even in those areas, you can have a lot of other structures. You have a lot of ligaments, bones, muscles, and tendons inside your feet that can be irritated. And it's just helpful to know if it is actually the plantar fascia or not. Plantar fasciitis can be very stubborn, as I'm sure Rick can attest to. Not fun. And stress fracture, right? So stress fracture is another one that we see in the feet that can be a result of poor biomechanics. So especially if you get a third or fourth metatarsal stress fracture, it generally means that you're trying to transfer power through those bones. So those are, your little toes over on the side, not your big toe. They're not really made to transfer power. They're there to give you more stability, to wrap around tree limbs and things like that, right? When you're running on uneven surface or anything. But where you want to generate powers through the big toe. And so a lot of times we'll see runners, maybe they're more of a supinator, or for whatever reason, they've got this idea that kind of throwing their ankle out and driving over their third and fourth toe is a better idea. And they end up with a stress fracture pretty easily. And that's another one that you could see that, well, if you have big toe pain for any reason or plantar fasciitis, you change your mechanics around the pain, even unconsciously, right? This is one of the things that's important to remember as a runner. When you start feeling a little uncomfortable in one spot, our brain is really good at protecting us, right? It's always kind of that animalistic, trying to protect us from pain, trying to hide the pain. And so sometimes when, those first few steps of the run are really painful, but, you warm up or things loosen up and you feel better. A lot of times what's actually happening is your body is adapting your running stride around that structure that's causing irritation. And those adaptations and modifications in your running stride are not always good because they happen suddenly, right? If you've learned anything about training, you don't want to do anything suddenly. We want any change to be gradual so that your body tissues can adapt to it. And if you're changing and modifying your running stride in a negative way very quickly, then that's where injury can occur as well. So ankle sprain, this is always a fun one, right? Everybody's run around the east side of Cincinnati on sidewalks.
Ellen, I just want to say one thing. Does everyone is good with what pronation and supination are? Is everyone Is it like if you had a question, ask it, but
I can just very quickly, right? It's the motion that's happening at your foot, the arch of your foot as it raises and it lowers in the simplest terms, right? So it's a normal mechanism of absorbing force as you hit the ground. And this is one of the reasons why we don't try to get rid of that motion. And it's one of the biggest things, you know, with shoe companies, stability shoes and trying to control pronation, right? Control shoes, stability shoes, things like that. And whether they're necessary for you or not depends on the amount and the pattern of motion in that midfoot and rear foot. And so that's, yeah, when I say pronation, it means the arch of your foot is kind of collapsing downward and inward. And when I talk about supination, it means the arch of your foot stays kind of arched up and your foot stays pretty rigid. It doesn't really absorb that motion. So then more things for foot and ankle sprain, and like I said, posterior tibialis tendinopathy. Ankle sprain is definitely more of a traumatic thing, right? Where you trip and fall or stumble, but I have seen ankle sprain that is more of a chronic type in people who have other issues, right? If you have a leg length discrepancy or for whatever reason, mobility in the joint is affected, and then you go and you run on it, sometimes you'll end up pulling and stressing ligaments that are generally there to provide structure and stability, but you're kind of forcing them to do something they're not very good at. And so then you can end up with a chronic ankle sprain. And then posterior tibialis tendinopathy, again, it can be a mechanics issue. If you're absorbing more force with the lower part of your leg as opposed to using your knee and hip to do it. So how do you treat these? I've kind of talked about it a little bit with each one, right? That there's very similar symptom presentations, but there are different sources. So we have a couple different case studies that we're going to kind of go through just so you can see the process of what we do in our head during that first hour appointment with you. We're always kind of comparing through a process called differential diagnosis, right? Well, I think it's this thing, but I need to make sure it's not 20 other things. And that's why all the little different tests that we have you do, and you know, testing your muscle strength and your joint range of motion and having you perform motions will give us more pieces of the puzzle to really see what is the structure that is irritated, because that's the first step of a diagnosis, right? Pinpoint what is hurt. And so, right, like I said before, if you got a little pain in the butt, these are all of the different things that it can be, right? SI pain, it could be even something coming from your spinal cord causing pain. And with each one of those, there are accompanying symptoms that we would be able to see. And the biggest reason why, as far as a runner, especially in the middle of a training program, why it's important to have a very, very accurate diagnosis is because many of these things have varied timelines, right? So this is the biggest reason why you want to see people, whether they're PTs, doctors, chiropractors, someone who is familiar with working with runners, right? Because often when people are not familiar with working with runners, right, what is their treatment? They say, well, don't run for 8 weeks and then come back and see me, or don't run, do PT, and then you'll feel fine. It's like, yeah, you probably will feel fine in 8 weeks, but you can't take 8 weeks off in the middle of the training season, especially if you had, you know, a PR or you were really determined to run this race, right? And so our biggest thing is, you know, unless it's absolutely necessary, I don't tell runners to stop running. I come up with a plan that generally is reduced mileage, cross training, things like that, right? We try to offload the tissue, but keep that cardiovascular fitness. And I know a few weeks ago, when Laura and Rick talked about, you know, the purpose of each kind of workout that you guys do, you can kind of hit those same targets and goals through different modes of cross training. And in a PT appointment, I'll help someone decide what is the kind of cross training that you enjoy. So how do we adapt that and do a hill repeat on a bike, or how do we do it on an elliptical or aqua jogging, things like that. So there are always options. If you go and you see someone and they tell you just to stop running, you know, unless it's a confirmed stress fracture and you need to be on crutches, we can probably get you back to running way, way before 8 weeks. And so that's just why accurate diagnosis is the first step in that. right? You might need 2 days off, you might need 10 days off, you might need a week. So again, these are things that have been kind of covered all season long, that affect and cause running injury, right? So volume, intensity, terrain, abnormal running. So that just means, like I said, if you're injured and you're changing and adapting your biomechanics or other weird things. I mean, there are definitely weird things that people have come to me and said that they try to start running like someone else and it's not good. It doesn't work. And so, yeah, abnormal running just covers a lot of things, whether it's, yeah.
You can go. You can go ahead and say it. You want to say five finger shoes that somebody ran trails on and broke three toes and doesn't understand why it's not working, and they should still wear them. And
I know. I have seen a few sand runners, right? And they
yeah.
are the people who can run in sand, right? It's all about adaptation and allowing your body the time it needs to be able to do those types of things. But you don't want to try that when you're also trying to like finish a marathon or I don't know. They're not great things. So shoe wear, definitely, you want to keep an eye on that and know how many miles you on average get out of a pair of shoes. A lot of people, who are very experienced runners will be able to tell you like, oh, I know exactly when it's time for new shoes because my knees start to get a little achy and things like that, right? And so when we talk about shoe wear, it's tread wear on the bottom, but also the foams that they use to make the soles and midsoles breaks down and becomes less responsive. And so it's not doing the job it's intended to do, whether that's to absorb force or transmit force or produce force, right? No matter what it is, there's always things that the shoe needs to be able to do that over time it stops doing. And then, weakness and mobility. And that's what warm-ups and strength training, stretching, all of that kind of stuff plays into those more general type of things. So the common formula, right? This is, again, just kind of how we do it. Identify the injured structure, identify the underlying dysfunction. So that's the biggest thing that is very, very hard to do on your own. And why sometimes you need a little help from a professional, right? Because you might be able to accurately diagnose that you have plantar fasciitis or it's your posterior tib tendon that is inflamed. And you say, okay, well, I know what it is. So at that point, a lot of people will, do the things that the internet says, try things that their friends have tried, whether it is K-tape or compression socks or a knee brace, things like that. And not that any of those are, complete wastes of money and they don't have their time and place, but you're not actually addressing the underlying dysfunction. Anytime that I prescribe orthotics, tape, a brace, those kind of things are meant to be short-term solutions that can kind of get you through this next phase of recovery and healing. But it definitely is not should not be your sole way of dealing with injury. And so these are all the different things that you want to be able to address and figure out which one is contributing to your problem. And that's why it's just helpful to have someone else look at the big picture and we're able to recognize the things that are causing that. And so then correct those dysfunctions. The biggest thing that I would say, get quality sleep and nutrition. Sleep and eat. If there's anything that I'm always harping on my injured runners, right? I always ask them, how are they sleeping? How are they eating? What are their current, stresses in life? Because another one that a lot of people don't take into account is stress that is, not in a physical sense. It really slows down our recovery and healing process in our body. And so you have to keep that stuff in mind, right? And it's one of the reasons why it's so hard to be an amateur athlete who has a 40-hour-a-week job, right? Anyone who has tried to train for a marathon or an Ironman tells you that you're always tired. You always have to do something. We don't have the luxury of taking naps every single day like professional athletes because we're not paid to do that. We're paid to go to work. And so as much as I would love everybody to be able to take a nap, I know that people have to go to the grocery store, people have to take care of their kids. And so, whatever you can do, and this is where conversations with other people who are supporting you in your life during the time of recovery of an injury is super important, making sure that you have the help that you need and figuring out a plan, right? That's the other thing, is really, really figure out, how am I going to recover from this? What's the plan in addition to my PT exercises? How else am I going to manage the rest of my life? So again, giving your body time to heal while finding alternate modalities, right? That's just cross training. That's all that means, to train your energy systems, right? Keeping the heart and lungs nice and strong and ready to go, so that as soon as your musculoskeletal system is healthy again, you can get back out there and feel okay. So the biggest mistakes: diagnosing themselves with Google, overusing NSAIDs. So if you are popping Advil like they are Skittles, right? Vitamin I, everybody calls it, before your runs or in order to get through your training for the season, it's a sign that you're really overextending yourself, and you need to kind of reevaluate how much you're running, how intensely you are running, and what your goals are for the season. And I have this conversation with almost every single injured runner that comes in, right? Because for every single person that I say, hey, this is your injury, we need to step back training for a little bit. What if I told you we're going to take 7 days off running? For every person who says, oh yeah, no problem at all, other people look at me and you can tell they break out into a cold sweat because they're not going to be able to run, right? We all want to get back to running. Ibuprofen is not the solution to that, unfortunately. The other biggest thing that I would really, really want everybody to know is that things like Advil and any sort of NSAID or anti-inflammatory protocol, herbs, ice baths, anything like that, you need to know that they decrease and blunt your training adaptation, right? So the more you use them throughout the season, especially in build blocks, right, at the early part of the season or in between seasons, you're really, really kind of selling yourself short, and you're not getting as much out of your training as your body could be getting. You're basically tricking your body into thinking, let's say you did a 10-mile run, you take Advil afterward, it makes your body think you only ran 5 miles. Something like that, right? Because you're decreasing that inflammatory response that actually improves your strength and your ability, not just at the musculoskeletal level, but at the cardiovascular level as well. So definitely try not to take too much ibuprofen unless you really, really need it to sleep, things like that. But it should not be, a normal thing that you use to get through the training season. And the same with ice baths and using ice. So I would say the biggest problem that I see, especially with muscular injuries, ice and stretch, right? Because what happens when muscle is injured is it tightens up in order to create stability, right? If a muscle is overexerted, it's a little overpulled, it tries to shorten itself, and then we stretch it. We stretch vulnerable tissue that's trying to heal itself, and we kind of rip it back open, and then we put ice on it, which also stops it from healing itself. And so a lot of times, especially let's say like hamstring strains or calf strains, the first thing I tell people, stop icing it, stop stretching it. We're going to put heat on it and you're going to let it do its thing. And it is very interesting how much quicker people get better. They come after they've had chronic strains for 6 months, and then within 2 weeks of not icing and not stretching, it's almost completely healed. So, and then number 4, like I said, going out and buying something in order to, fix the problem when you're not even really sure what it is. Everybody tries that and it's fine. I expect it. I always ask an injured runner, what have you tried so far? And I expect them to say, I tried tape, I tried shoes. And that is important information for me to know, because it helps, it's just another piece of the puzzle, and I'm able to kind of tell what's going to work and what's not. So here's a case study. So a runner, she came in with pain in the heel, behind the ankle, and the Achilles tendon, outer foot. She hasn't been able to train for a year. Every time she tries to run, it flares up again. She's really, really frustrated, and she wants to be able to run, but she also wants to be able to train for a full marathon, right? And so what has she done? She's tried 3 different shoes. She's gotten inserts from the shoe store because they told her she was an overpronator. But then she went to an ortho and a podiatrist, and they both tried things, cortisone injection, course of steroids, and a Z-Pack. and then went to standard physical therapy as well, but still was not back running yet. So after we did a thorough physical and movement exam, right? So the movement exam is the biggest piece that a lot of PT offices don't do. Also put her in an appropriate shoe for her foot, looked at her running form, which is another step a lot of PT offices will not do, and then got her on a return to running schedule. Because one of the biggest things, especially if you've been dealing with an injury for months, or, we do see people who've been dealing for like a year or more, you're probably not the runner that you were to start with, right? And so you think that a 6-mile run is easy. Your body might not be there anymore. It might be ready for a 1 or 2-mile run. And so really starting back easy and figuring out what's the appropriate amount of running to be doing, things like that. So then also looking at technique, cadence is one of the biggest changes that we can make that really make a very, very, very quick improvement in someone's pain and dysfunction. And activation, right? Doing warm-up drills, strength and conditioning, all of that kind of stuff. She's able to run and is training for a half right now. So it does work. Our process works, and it's a lot of fun to see runners. My biggest thing, if you are starting to experience pain and, you're not quite sure what to do, right? So the first thing, whether you want to do it on your own or you want help, is decrease your load. I generally tell people cut your load by 50%, whether that is days, whether that is intensity, just decrease the load on your body by 50%. And that's going to give your body a chance for recovery, right? So recovery is the opposite of injury. If we let our body recover, it's going to feel a lot better. The second thing I say is don't panic, right? Just because you're starting to feel a little something and it doesn't feel right doesn't mean your entire training season is out the window. And it doesn't mean that, you're not going to make it to the start line or the finish line, anything like that. So you just have to get a process and a plan, feel good about it, and it's really going to work. So when can you push through pain, right? Because we all know that, I'm going to stop sharing this so you guys can see me. Can you see me again? Awesome. So when can you push through pain, and when do you need to stop and pull the plug or modify, right? So the general rule of thumb on a 0 to 10 scale of pain, where 0 is no pain, you feel awesome, and 10 is excruciating pain, you can't walk, you need to go to the emergency room, your leg is falling off, things like that. Anything below 3 on that scale is generally acceptable and kind of to be expected, especially as the training season progresses, right? When you get into month 3 of your marathon training plan, you're not going to feel like a 0 out of 10 pain all the time. So a little discomfort is okay, and it's part of the process. The biggest thing is if the pain is bad enough that it's causing an asymmetric gait. If you are actively limping and everyone around you can see that you're in pain, you need to stop running probably and walk it in, and take a few days off. But the biggest thing is really, what is the pattern of symptoms for 24 to 48 hours after that run? So a lot of times when I'm returning runners to running, I say, okay, you're going to go out and you're going to try this run, whatever the plan is. And then you're going to think about, okay, how did it feel while I was running? How did it feel 24 hours later and 48 hours later? That kind of information tells us the level of irritability and vulnerability of the tissue and the injured structure. If that pain goes away within 24 to 48 hours, you're probably in a pretty good spot, just to reduce your load and run fewer days per week, but still continue with the training plan. And again, just really prioritize recovery and adaptation. Let your body do its thing. We just tend to get in the way because we get excited and want to run every single day. We want to run 100 miles a week. And like I said, it's just really hard to do unless you're able to take a solid nap every single day and you have, a cook on staff who's going to make you 3 nice meals and you don't have anything else to worry about. And I don't have that. I don't know about you guys, but yeah, I guess that's kind of it as far as what I have. I know it's a lot of information and it is a really hard topic to cover because there are so many injuries and so many different causes. But if you really understand the global concepts of injury prevention, and then the process, how we treat injury. That's really what I wanted you guys to take away. But if anybody has specific injuries they want to ask me about, go ahead.
I want to say one thing real quick before people jump in, and then Aaron did ask a question in the chat. But one thing I wanted to point out that Ellen kind of alluded to, but there's two pieces of the puzzle of like, where she's talking about reducing mileage and reducing, let's say, intensity. So, if you're out, you're feeling pain, a lot of us will run through it because we say, oh, this is what happens. It's training, we have injuries, we have issues, and you kind of deal with it, you run through it. The other issue is that. So, rather than just saying we reduce, let's say, our overall mileage, it's also okay to just cut the run. Some of us will be out on a, 14, 10, 12, 13 mile run, whatever it might be, even longer, and say, I'm 8 miles in, I'm in agony, but I only have, 6 miles left. So I'll just finish it because it's just 6 miles. When we do that, we tend to cause more damage and actually set ourselves back time-wise. And I get the question all the time, well, hey, I missed my run, now what do I do? The answer is fine. Missing a run or dropping mileage or not finishing a long run or not finishing a workout, all of those things are fine. The way a training program is built, there's enough volume and opportunity to pick up speed workouts and distance and the mileage and all the things that come along with a full training program, that cutting one run short will typically benefit you, not hurt you. So if you have to make a choice between continuing on in pain just to finish something or cutting it short because you think it's probably the right choice, it's probably the right choice. Cut it, move on, and then assess, what comes next. Because you can really set yourself much further back if you continue on. So
absolutely, 100%. Rick is so right with that. And that is kind of one of the biggest things, right? And it is easier when someone comes earlier in their training season and they have these issues, and I'm able to say, like, just don't worry about it, right? Like, you're not going to do that run, or, we're going to do something else instead. You're going to cross train. Like, it's not that big a deal. Like he said, there's enough volume in the training plans. They're very well designed that you're going to make it to the end of the season if you have to drop a run here or there, right? The training plan includes options for every single day almost, right? But really, we can get a lot of people to a successful marathon running 3 days a week, right? 3 or 4 days a week is completely fine. And so you have to look at those other kind of easy run days. What benefit are you getting out of some of the runs? It's always a choice. When you start a run, what is the purpose of it? And does the benefit outweigh the cost? Because a lot of times when you're in that injury cycle and in that injury phase, the cost is much higher than the benefit. And it's better to allow your body just to rest and recover, and knowing your body, right? And a lot of what Rick was saying, it comes from being a very experienced runner and doing it for a lot of years. And it's something that, if you haven't been running that long, you definitely will learn. Your body, because, some people, their bodies really are beat up by speed work, but other people, they might really be beat up by long runs. And so with either of those scenarios, a lot of times I'll modify someone's training plan and say, listen, if you feel like crap after long runs and you really have a hard time maintaining form, and you don't quite have the strength yet to do some of those double-digit runs, it's okay to do maybe a long run every other week or skip a long run every third week. Things like that are really, really good choices. And, there are a lot of training philosophies that can get you there successfully. And that's one of the funnest things about my job, is that not only do I get to coach, and see wonderful BE athletes from our training group, I see people from training groups throughout the city. I see Fleet Feet runners. I see House of Run and Try, right? I see people who have other, online remote coaches and who are following.
All of these people, by the way, are much less happy than the people that are in this group and much less successful.
Yes, absolutely. That's what I'm saying. They're and they're crying, and it's just terrible.
A lot of tears, a lot of agony, a lot of sorrow.
And they talk about how mean everybody is. And it's no fun at all. But so right, there are a lot of different training philosophies, and that's what a well-structured training plan allows, that flexibility. Like I know that he said before, if you have vacation, don't worry about it. And even with PT, no matter what injury you're dealing with during this time of year, I have a lot of people going on vacation they come back and they feel so guilty that they haven't done their PT exercises or they didn't go on any runs. And I'm like, that's no big deal. You were on vacation. That's what you weren't supposed to do, that kind of stuff. That I would be really worried if you were like, oh yeah, I did my PT for an hour every single day. No, I want you to be on the beach relaxing, because honestly, that's better for recovery than doing PT stuff. But yeah. So looking at the chat from Aaron asking about, running is so hard on your knees. Oh, you're going to need a knee replacement. Your knees are going to hurt all the time. No, it's all a load of crap. So we really have found through research studies that runners have lower rates of osteoarthritis in their knees. They have thicker, more resilient cartilage in their knees as they age, because you are applying that stress and your body is adapting to it. And so that's the biggest thing. No matter what activity it is, as you age, if you're not applying stress, that's when your body starts to break down, right? If you're not using your knees as much, your cartilage starts to, thin and can have imperfections and things like that. And so really, yeah, they've done a ton of research studies. It's not going to ruin your knees. That being said, I do see a lot of very active people who have, bad knees because they were really active as a kid. And there are certain activities that we know, if you've had an acute injury like an ACL tear and reconstruction or different types of surgical interventions, you are a little bit more prone to osteoarthritis. And it's one of the reasons why we really tried to find non-surgical options prior to surgical options, because any type of intervention where they're cutting into your knee does introduce the opportunity for a little arthritis down the road, but running is not one of those.
I was just going to say, is there any incidents, maybe to further Aaron's question, is there any incidents to, like, let's say lateral movement, so, like a soccer player or something like that versus a runner where it's very linear movement, that contributes more to knee issues or even leg issues?
I haven't seen it as far as a certain activity. What we do see are certain biomechanical factors, right? So we do know that people, if their patella tracks a certain way, can have issues with the cartilage on the underside of the patella, things like that. And even with those type of biomechanical considerations and anatomical things that you really can't change, right? We can't change the angle of our femur and the angle that the patella tracks. We can use tape to kind of influence it a little bit, but we can't really change it. So those things are generally more likely to. And so that's why we can say as a whole, running doesn't ruin your knees. But if you have some of these issues and then you run, it can be a problem. But that even gets into tricky territory. And I don't like to say that kind of stuff because really, if your training is solid and you find kind of that happy place where your body is adapting appropriately and you're not pushing yourself too hard, even if you have jacked up mechanics, you can still run pain-free. And so one of the best examples of this is when I worked at Children's Hospital in the OT-PT department. I was involved in a group for runners there where it was all kids with different developmental disabilities. They had cerebral palsy and Down syndrome and things like that. And so these kids have, biomechanical challenges where their range of motion is not symmetric left and right. And they use, very aggressive bracing and orthotics and things like that. But they're still able to train and not have any pain. And so if you look at those kids and they're able to run without any problem at all, anyone else should be able to. But you just have to take it really slow, right? So if you know that you have some of those biomechanical things that maybe make you more prone to have pain and injury, it's doing mobility, doing, foam rolling or strength training, whatever it is for your body that can really kind of get you to where you want to be. There are really few things when people come into my office. I don't think I've ever said like, oh, you need to stop running. Like I've never had anyone where I'm like, yeah, you really shouldn't run. Even when doctors tell people that, we can generally get them at least to a 10K distance and a half distance. Sometimes, marathon is definitely a little harder, but it's going to be a slower process. You just really have to be patient.
Sheila had I think Sheila had a question. Her hand is raised. I didn't know she had a specific question, but if so, maybe not. Sheila, if you have a question, yeah. Hey, Chris. If, if Sheila has a question, Sheila, you're welcome to unmute. Oh, no question. It just says your hand was raised. Perfect. And Laura Blackerby, I don't know if you guys can see Laura's comment, which I think is a great point. Laura has rheumatoid arthritis and, famously has migrated, if you will, from running to walking, but with an intensity that I would argue is probably more intense than the rest of us who are running. And as she says here, she hasn't had issues with her knees. So, I think, Aaron, to kind of piggyback on what Ellen said, we've heard it forever that, oh man, you run, your knees are got to be trashed, right? Or I don't run. Yeah, the one I hear honestly almost more often is, I don't run because of my knees, or I don't run because I know what it can do to my knees. People, this is typically from somebody who doesn't run, not from someone who does. I don't know that yeah, exactly. I don't think I've ever really heard anyone who is a runner say, oh, I got to a point where I could no longer run because of my knees. I don't know, honestly, I've ever really heard that. It's typically from people who don't, and or have some other resultant injury from something where it's a specific injury.
Right.
But, I've run for, because I'm old, I've run for 20, almost 25 years, fairly consistently and fairly heavily. And I have a little niggly, as to use Ellen's word, little niggly injuries here and there, but nothing that, has prevented me from, getting in a marathon or two a year and that kind of thing. So nothing that's disruptive in a major way.
Yeah, it is generally the people who are like non-runners who try to run, but one of the biggest things that I talk a lot about with my runners when they come to see me is that, we're not taught the skills of running. There's not skill development in the same way that we have for other sports, right? And so a lot of the things that we teach during PT sessions, I think, are things that we should be teaching in PE in elementary school, right? How to warm up, how to run with good form. But it's just thought that it's intuitive and that, just how you run is how you run and you can't change it. And so most of the time when people say that their knees really, really don't like running and that's why they don't run, they're generally, overstriders who are landing really hard on their heel out in front of them with a very straight knee. And so they get, pretty severe patellofemoral pain syndrome. And so then they think that they just can't run because they're trying to do too much too soon. And I have seen a little bit of that during COVID. COVID injuries have been an interesting mix because half of them are from people working from home that have crappy work setups that are working on their sofas or on their beds and things like that, or their kitchen chairs. And the other half are people who started at-home workout plans. It's interesting. And there are people who have kind of taken up running and are learning its joys for the first time.
Chris, no, I'm kidding.
I have a question. So circling back on the topic of quality diet and sleep, I'd been taught before that you can gauge if you're starting to get injured based on your resting heart rate dip. Is there any variability to that? Is that kind of a pseudoscience or what?
So there are devices now, and I think even some of the Garmin's now are looking at HRV, right? Heart rate variability. There's Whoop is a wristband. There's an Aura ring, I think, is another one. And so these ways of looking at your resting heart rate to predict injury. And there is a little bit, but I'm going to say I was using HRV tracking and got injured, and it didn't tell me that I was about ready to get injured. And so I think it just depends on the person and the type of device that you're using and how sensitive it is. Because physiologically, the science is sound. We've seen it in like heart patients and people like that. Running injury, there are so many other variables. And it's hard when you're kind of right on that edge, as a lot of times people kind of reaching for PRs are, right? You really have to push yourself right to where you're almost at that capacity and that threshold. And I don't know, I haven't seen anyone tell me that they really have, missed an injury, like, oh my God, I was almost injured, but you don't know, right? If you didn't get injured, were you still going to get injured, or were you able to back off? Things like that. So it's hard to say. Because I think everybody who runs with a Garmin knows that some of the advice and stats that Garmin's give us are a little questionable at times. Those predicted race times and your suggested recovery times are very interesting. And I'd like to see their algorithm for it because, I run 5 miles and it tells me I need 72 hours to recover from it. So, like what is their idea of recovery and things like that. And they told me I could run like a 16-minute 5K, which is not possible, right? No. And so that's where, it just depends on the device. I don't really know. I don't have a great answer. I know it is emerging science though, because I think that's the idea. They've given these devices to like NBA players and, NFL and NCAA and stuff to try to maybe predict COVID, right? To see if you can see it in your heart rate before you see it in other types of symptoms. And I just don't know yet. We don't have enough information.
Yeah, there's an enormous amount of debate with specifically. I know you weren't asking specifically about Garmin, Chris, at least I don't think you were, but there is a lot of debate about some of the Garmin metrics that are now being added. There's an enormous number of metrics that Garmin, sort of trickles down from the Phoenix watches, down the line and continues to introduce into some of the more, we'll say, kind of mid-level and even lower level models. And a lot of it is what we would call useful data, depending on what it is, of course, you're using the data for. But the accuracy of it and often the really viability of it, I guess I would say, it comes into question a lot. Like to Ellen's point, I mean, the recovery suggestion, the recovery recommendations, the time predictions, the race predictions, there's a lot, the number of calories, you burned, when you're, I mean, a lot of these things, and it's all an algorithm, obviously, it's electronic. It doesn't know you. It knows your metrics and your stats, and so it takes that and it runs it through an algorithm. Those algorithms are a constant across millions and millions and millions of athletes, and so I really caution people. To be brutally honest with you, I typically say use your Garmin for distance, pace, and mileage. I mean, it's kind of what I say, just because I think otherwise you get into a real fuzzy area that I think can call a lot of people into question. A lot of people get concerned about it too. That's kind of was my point, was saying it trickles down. Trickle down in technology is great when people are educated how to use that technology, and that technology can often startle people when they look and they go, what's my VO2 max? Why? I didn't know I needed to know what my VO2, all of a sudden you have like people freaking out because they want to know what their VO2 max is and their, oxygen consumption, what they're burning, and, aerobic heart zones. And it's like, oh God, it just opens a can of worms. And it's often, again, it's not that it's not useful information, but if the information is not, shown in a way that can be totally accurate and used for other purposes, I honestly think it can sometimes do a disservice to the people who are looking at it. So.
Yeah, absolutely. I mean, I'm a physiology nerd and have tried all of the apps that are out there at different times. And yeah, like Rick said, the information that these apps and devices give you, like what is the point of it and how useful is it to you? And how much is it just like a cool thing that you're like, oh, I know what my VO2 max is, right? Like that's not even really that useful that much anymore outside of a lab setting where we're testing people to see if different training protocols work, because VO2 max is not a predictor of performance, really. It means that you're maybe in good physical condition for your body, but it doesn't mean anything about how you're going to compete or how you're going to race on a certain day or anything like that. So yeah, you just really have to be cautious. As far as anything that can help predict or kind of alert you when maybe you're overreaching a little bit, some of the devices and apps that are out there now, I think, one of the classic ones is Training Peaks. If anyone has done multi-sport, they definitely probably have had some interaction with Training Peaks. It, gives you other metrics like TSS and it shows you these little bar graphs that show your acute training load versus your chronic training load and things like that. And so sometimes you can see, you know, when your form and fatigue and all these different, you know, trademark kind of terms that they've come up with, you can kind of see when maybe you're not, you know, training productively, right? You're just doing miles to get the miles and to finish the training run. But if your heart rate is super, super high on what's supposed to be a really slow, easy run for you, things like that. Or yeah, if your heart rate constantly is a little bit higher, as opposed to lower, honestly, I would be more concerned if someone has a really high resting heart rate when they normally do not, because it's a sign their body is under much more stress. The other one that is trying to, like I said, predict injury is Whoop. That gives you a recovery score on a daily basis. And then you take that to, you know, decide if you're going to follow your prescribed training or if you're going to decrease it a little bit or skip it because your body needs more rest. It really tracks your sleep more than anything, your sleep and your HRV. And with those two things, you can kind of see like, okay, what is the state of my body? Am I really giving it enough time to recover? So other than that, I haven't really heard about anything that accurately or, you know, even purports to predict injury.
One of the things I would just recommend is like look at, you know, especially like think about a Garmin. Most of us use them. You know, think about what a Garmin is and what it's best at doing. It's typically a physical, measurable thing that is a constant that applies pretty much to everyone. I mean, Garmin uses a satellite that's up in space to track our distance and our mileage and our pace and all these things. And so think about the physical stuff will typically be good and accurate and informative. The physiological things are interpolations. And so they are created out of other numbers. My wife is shocked that I just used the word interpolation. Are you shocked because it's wrong? Or are you shocked just because I used a word bigger than dog? I think she's literally just like, she had like food in her mouth and stopped and like looked at me like, did you just use something that was like more than one syllable? And so when something interpolated data, thank you, can often is where the flawing can often occur, and where you know how we see it, how we view it, how we use it. That's when it can often be dangerous. So,
yeah.
Leslie, I believe, has a question. Sorry.
Yeah, that's good to know. Full disclosure, and I'm gonna get crucified for this. I've been using an Apple Watch to run with.
Oh God! Oh God!
I don't judge you.
Ooh. But the main reason is A, for work, but B is I use it when I sleep, and it does the
sure
resting heart rate and that kind of stuff, and it lets me export it into Excel. And so the math nerd in me likes to plot everything, and the correlations are all over the board. And so I know correlation doesn't determine causation, but just to try and map up and see anything, and it's just been, you know,
here's what I would tell you about the Apple Watch, which is an interesting. You're probably using it actually the way in which it is intended, and it is good at. What it is not good at is the physical things, the distance, the mileage, the pacing. It's terrible, and I don't know why, but every single person I've ever talked to that's used an Apple Watch, like, you know, for running or cycling or whatever, that's the complaint, oddly enough. It's the other things where I think they've put their technology and they've put their, I'll say, research and development is into some of the things you're talking about, which is, you know, sleep and heart, you know, things related to the heart rate. So oddly enough, you know, I get it. I mean, a lot of people use them for work because they get a benefit through their insurance company or whatever. And so it makes total sense. But oddly enough, the only, you know, wah that I would say to your, you know, comment about an Apple Watch is the basics, the distance, mileage, the pace. Those were the issues that I've heard of, at least. So
the only upside to it is that anytime we do a run, my pace is usually like 4 to 5 seconds faster than Drew's.
Yeah,
so,
well,
but outside of that,
I mean, it is Drew, so everybody should be 4 to 5 seconds faster than Drew.
Just kidding. Yeah.
Kidding. Sorry, he's not on here, so we can say that.
Cool. No, I appreciate that, Alan. That's good answers. Appreciate it, guys.
Leslie Jane.
Hi.
Hi.
My question is about ice versus heat. So it sounds like you're not a super huge proponent of ice, but like anytime I've been injured or have seen a doctor or physical therapist about anything, I always ask the question, ice or heat, which one's better? And the answer I always get is whichever one makes you feel better. And I don't always know which one makes me feel better. Sometimes they don't at all, and sometimes they might. So what is your opinion about when to use which one.
Yeah, absolutely. It is definitely confusing. And a lot of us as professionals don't have straight answers about it. I do tell people, like if you love ice and you use ice and it makes you feel good, go for it. But the thing to understand about both of them is, looking at what is the goal of it. If it's, pain reduction and pain control, ice can generally be better for that. If it's to promote healing, then heat is probably going to be better. Just because, is Laura saying something to Rick about what I'm saying? No. Oh, okay. But so heat, right, is a vasodilator, meaning it's going to bring more blood flow to the area. Some of the time, some of these injured structures don't have great blood flow, right? Tendons, ligaments, cartilage, things that if you think about, they're white. It means that there's not a lot of blood flow. So we want to do everything we can to bring blood flow to that area to improve healing. And that's where heat can come in. And I tell people, 20 to 30 minutes, whether it is soak in a tub or a whirlpool, hot tub, or a heating pad is fine. But sometimes it can make things a little irritated and people don't necessarily like that feeling. It's okay to kind of follow it up with ice, knowing it's a vasoconstrictor and it's going to limit blood flow to the area, but it's also going to inhibit pain and make things feel a little bit better. And so that's where when, a PT or a doctor is like, whatever feels better, most of the time I generally try to give you, a stronger recommendation of do both or do contrast, right? So when you're using both, it's generally referred to as contrast. Long term, does either one really do that much to promote healing? We don't have a ton of evidence, looking at the cellular structure of things, but it's all theoretical, what feels good, what's going to make you more confident and decrease your pain so that you can sleep, so you can perform, right? And so this is where I generally recommend for my athletes, ice is okay to kind of get you to be able to perform, whether it is an ice bath so that you have a fresh body, fresh legs, things feel really good, you have lower inflammation. But again, right, it's going to blunt the training adaptation. So don't do it long-term to, manage something that's an ongoing chronic issue. We generally say more acute injuries or inflammation, use ice. So if it's within the first 48 hours of an acute injury, apply ice to it or surgery. But after that, you really don't need to use ice that much. So.
Okay, thank you.
Yeah.
Where is mud? Not your fault, just
I know it is. It's a tough one. There are PTs out there now that are telling people never, ever, ever use ice. Don't do it. Only ever use your hot tub, but what do, right? Orthopedics will recommend ice. Anytime you Google something, put ice on it because it can temporarily kind of make things feel good. And if that's all you need, if it's not like a true full-blown injury, sometimes ice is a good management strategy and can kind of help get you through. But it's hard to say that it's a good long-term plan.
Laura's probably saying, I've answered this question 500 times.
She said 1,500. She's literally sitting like right here. And,
I know.
And she's just like,
saying about it.
She's shaking her head at Leslie going, damn you, Leslie, I've told you before.
No, she has.
Well,
I think it's not so much that I don't, like, I understand what the different ones do. It's that depending on what the pain is, I don't know if it's inflamed or if it's injured. So
Yeah.
which one I don't want to do one that's going to cause it to be worse.
Yeah.
No, I think it's a great question. I mean, I live with it, meaning that's over here. And I'm not sure I get it either, and I think that's the point. I think there's not always, unless you know exactly what the injury is, there's also not necessarily a way to ensure you know exactly what the treatment should be, right?
What usually ends up happening is that I just don't do either because I don't know and I'm lazy. So I guess it doesn't really matter.
And that's the other thing, because
People that do that. I have a ton of people that won't use heat or ice. I have other people who use both of them. I have people who swear by one or the other, right? And my job is not necessarily to change someone's mind about what they believe about heat or ice, right? And so that's why, and that's kind of, I think, the general consensus among doctors and PTs and stuff right now. If someone's going to like fight you to the death because they want to use ice, you're going to let them use ice because it makes them feel good. And that's the most important thing, right? If they feel like they're getting that therapeutic benefit from ice, I'm going to let them use ice. I'm just going to tell them, hey, just so you know, this is going to cut down on blood flow. It might slow your healing time. There are certain injuries that I would say you never, ever, ever want to ice, including stress fractures. Please don't ice your stress fractures. I know it feels good because they're very painful and achy, but it slows the healing so much. NSAIDs and ice are two things you never, ever want to do with stress fractures unless they're so incredibly painful that you can't walk on them and you need to control the pain. But there are a lot of studies that show that it really does delay healing time and the time that we're going to get you back out on the road.
Okay.
I got a question in addition to Leslie's. So if I feel like I get injured out on a run, like my calf pulls or something, then do I put ice on it when I get back or heat?
I would say don't put ice on it. I know that is what a lot of people do. It is, again, one of those things. I would say if you want to put ice on it, just do it in the first 24 to 48 hours and then kind of reassess. If it's feeling tight, I would say kind of leave it alone and then maybe use some heat on it. But again,
Okay. Well, that's opposite to my, I usually, because it's usually a week before I need to go see a PT, like I'll pull my ankle or something, then I'll tend to put ice on and take ibuprofen. Is that the wrong thing to do?
No, it's completely fine. Because then by the time you see me, you're already out of that acute inflammatory cycle, that first 7 to 10 days, and you're probably kind of moved on to the next phase. And so at that point, I'm going to encourage you, maybe let's use some heat, let's get some gentle motion in it, things like that. They really are changing the recommendation for RICE though. So rest, ice, compression, elevation. There are a lot of other acronyms that people have created that are just not good. There's one that I saw that's called POLICE. There's one that's peace and love. And I don't even know what all these different letters stand for, right? But the idea is that sometimes instead of not doing anything, right? Instead of laying on the couch, not putting weight on it and just putting ice on it, we really want to get a little bit of gentle motion, right? That's where like a nice walk or some yoga, something like that is going to be okay. And then heat is really kind of one of the things that a lot of people are promoting.
Thanks.
Yeah. So I see in the chat that Laura asked about cupping. I do perform cupping therapy. How I use it depends on what I am cupping and the reason for it. Traditionally it is from traditional Chinese medicine. So there is not, necessarily what they say happens when you cup is not necessarily actually what is happening or the reason why I do it. I use it as a novel stimulus to your neuromuscular system to try to just get your body to respond a little bit differently, right? I'm not breaking up scar tissue. I'm not breaking up adhesions. I'm not pulling toxins out of your muscles or your skin. I don't really believe that that's how it works. But what I think it does is throughout our body, we have little nerve endings, and some of them have sensors on them called mechanoreceptors, which are little nerves that just sense physical deformation. So when you press on something, when you stretch something, and you sense that, those are mechanoreceptors, right? And so cupping can activate those because you, instead of pushing down like a massage or an active release, something like that, we're pulling up and trying to create more space and pull the tissues away from each other. And all that does is it provides a different type of input to the brain. And sometimes that can decrease your pain response. It can improve blood flow to the area. So sometimes I will use it to promote healing, but it's not any better than traditional massage techniques or Graston scraping type therapy, all of those kind of things. If people feel really good and like cupping, it's definitely one of the tools in my toolbox. But I definitely use it more in a dynamic way. I don't leave bruises when I do it. It can be helpful though.
Thank you.
Yeah.
All right. Anybody else have any questions? Thoughts? Aaron, I saw your message. I misunderstood the Vaporfly thing. That was just for Chris and his Vaporflies. No, he said.
I do have a quick question. So what's the current status with appointments and that sort of thing. If we need to get in to see one of the PTs, you, Ellen, or someone else, or to do even a form analysis or shoe analysis or whatever, what's the current protocol going on right now for
Yeah.
y'all?
So all PTs, we are working at full capacity at BE now. We are only booking appointments through phone though. So you have to call the office in order to book. We have deactivated online booking. And the only reason is because we're controlling how many people can be in the facility at one time to reduce risk. We are all wearing masks, obviously. We're taking temperature at the door. You know, if the session is taking place in the private treatment room, it's just you and your PT in there. There's the receptionist. We're staggering appointment times to try to reduce the amount of people arriving at the same time, right? So if we have two PTs working, one person's patients arrive at the top of the hour, the other on the half hour, things like that, just to try to reduce how many people are crossing paths in the lobby and in the gym, things like that. In the gym, we've rearranged everything. I think at max, personal trainers can have 4 clients, and then no more than 2 personal trainers working at a time. And so if there are 2 of them, there will only be 4 total people in the gym because we leave room for PTs. But yeah, if you need anything, you have to call to book. And, you know, we've updated some of the information on the website. If you guys have questions specifically and you're not sure if you need to come in, you can always shoot me an email or any of the PTs that you guys have previously worked with. Does that answer your question?
Mm-hmm. Yes, thanks.
Yeah, we're doing all, you know, every type of appointment is available. So we are doing run evaluations. We're doing stride analysis, which is something Eric told me to talk about that I didn't talk about. Sorry, we do stride analysis. Everybody should come get one. It allows us. So that is the one thing, actually, I totally forgot. That is the one thing that where we can see an injury coming if it's not quite there yet. It's a form of gait analysis on our treadmill where we can see tiny asymmetries that we can't see or hear with our eyes, or with our ears, obviously. And so basically it slows down the running speed in the computer, and we can see, you know, how much time you're spending on your left foot versus your right foot in each phase of running. So that is another service that we offer that can help predict injury.
We've talked a lot about in other you know, with Eric Schneider and Eric Oliver, fairly extensively the stride analysis and the benefit. I mean, I'm a big proponent, so we talked a lot about the benefits.
Now Eric just told me to like sell our services.
Yeah, that's right. Buy it now. Buy now. Well, I mean, the stride analysis. I mean, honestly, if you haven't had one, I think it's a great investment. I really do. I
It's
think
cool. It's a fun thing. It definitely is fun too. If you're kind of at that stage where you're like, oh, why can't I break through the next level, right? If you really want to get that BQ or you have a certain goal time in mind, you know, these are the things, if you're non-injured, that we can help you make those changes appropriately, as opposed to just going out and trying harder on your own and maybe ending up with an injury or just not knowing where to start. So we can do a lot in that sense, even if you're not injured, right? We're doing the like runners injury prevention things where we find all of the little things that you can do to be faster runner, injury free. So
I mean, if your goal is just to be 4 to 5, 6 seconds faster than Drew, then they have the tools for you. Get an Apple Watch, talk to Chris, and see Ellen.
yeah, for sure.
You too can run 5 seconds faster than Drew. That should be like our new little tagline.
Do you guys just want me to make Drew slower? That could work.
Yeah,
too.
that would be good. We
I'm
can,
okay with
we
that.
can,
Please do.
what's it called? Kneecapping someone? What do you call it when you give them the Nancy Kerrigan treatment? Clock them in the knee. Sorry, I don't. Problem solved. I like that Julie Krause rejoined on video right when I made the Nancy Kerrigan comment. Julie's like, I'm back. What did you say about Nancy Kerrigan?
I don't have anything to add if anybody doesn't have any questions, and it's definitely past my bedtime now.
That's right. Good night, night.
Yeah.
All right. Everyone good? Any more questions?
Yeah.
Everyone good?
It was wonderful.
Thanks a lot.
Everybody. I'll see you guys.
Thanks,
around.
Ellen.
Okay, well,
Thanks,
thanks.
Ellen.
That was
Very
like
helpful.
you hit everything on
Thanks.
point there.
Okay.
Much
If anything
appreciated.
was confusing, I can always follow up email if anybody is still not clear on ice and heat, or if it's bad for your knees. I know we don't have a lot of straight answers as PTs. It's really, really hard. You know,
I'm not allowed to ask anymore. Laura might kill me.
the problem is that
Over there. She can't get you.
our only answer is it depends, right? They even make that joke in PT school when they're teaching us. They're like, there's never a straight answer for anything. And so this is though one of the reasons why you need to be wary of people who have straight answers for things. So if they know it all, you gotta be
Probably not right.
yeah, because it's very dependent on your circumstance. And I tell everybody that, any running injury is really a perfect storm of things that happen to you that might not happen to another person, right? It's your mechanics, it's the route that you ran, the shoes that you're wearing, what you ate for dinner yesterday, how much sleep you got last night, if your job is stressing you out, what time of day you are running. All of those little puzzle pieces come together to create your special injury.
Congratulations. Ta-da! Oh, there.
My applause track. Yeah.
Beautiful. Well, thank you, Ellen. It was great.
You're welcome. It was good to see
Thanks,
people with
Ellen.
masks on their face. Some
That's
of them
right.
see your face for the first time. It's great.
Nice.
Yep.
All right, guys. Well, thank you again, as always. I hope everyone has a great week. Take care of yourselves. Stay safe. And don't forget, ice and heat. Ice and heat. Ice and heat.
Both at the same time.
Yeah. Or just, both. Pile it all on.
Yeah.
All right, guys. Have a great week. Thanks again.
Hey,
Uh,
Take care.
happy
Bye.
see ya.
Have a good night, guys.